Okay, so it is not about the diagnosis, by the way, because whenever you enter the station, by just looking into your patient, you know that this patient has got Gravis. And since the complaint from outside is tachycardia, he is in thyrotoxic state, possibly with atrial fibrillation. Okay, just by general inspection and by the complaint from outside. But in cases when you apply for a specialty level exam, it is never about the diagnosis. They will need you to search for complications. They will need you to search for associations. Okay, and also they expect you to put a full plan of management covering everything. Okay, so let us assume that I would like to cover this case from outside, just from outside. By the way, there is findings you can mention to the examiner. What kind of findings are mentioned in the scenario from outside? Any idea? I will post the scenario again. Just a minute.
Tachycardia.
Exactly, tachycardia.
Maybe due to anemia.
Or thyrotoxicosis, right? Thyrotoxicosis per se can result in tachycardia, so whether this is sinus tachycardia or atrial fibrillation. And again, also, there is wide pulse pressure, which is typical for any hyperdynamic circulation, whether this is due to pregnancy, fever, thyrotoxicosis. Okay, the blood pressure, if you calculate the pulse pressure for this case, it's around 65. Usually, from outside, they will give you a hint. Okay, palpitations. Whenever you find palpitations, and or palpitations or weight loss, and from outside they mention tachycardia. Usually, your case is thyrotoxicosis. And most of the time it is Gravis disease, because the most common cause of thyrotoxicosis is Gravis, by the way. So, what other causes of thyrotoxicosis you might face?
Multinodular goiter and toxic adenoma.
Toxic adenoma.
And thyroiditis, subacute thyroiditis.
Exactly. So toxic adenoma of the thyroid or pituitary, it is rare. It's a little bit rare. But apart from Gravis, you can mention postpartum and post-viral thyroiditis. I mean decurvent thyroiditis. Okay. Sometimes thyroid intake from outside. Okay, but the most common cause is Gravis disease, whether in real life or in the exam setting. Okay, so when I enter the session, I will introduce myself using my third name and my role, and then I will confirm the patient identity, and then I will take permission for both history and examination. Hello there, my name is Dr. Tahir, one of the medical doctors in the clinic today. Is it Miss Glinda? Yes, doctor. No need to confirm by name and age, by the way. Keep it simple. Okay, so Miss Glinda, I would like to ask you a few questions regarding your health, and I may need to examine you. Sure, doctor. So here I will start by open question. Could you please tell me what brought you into clinic today? Doctor, I have got problem with heart racing. I have got heart racing. So by the way, analysis of the complaint is fixed for all complaints, regardless of your complaint. If you have approach to analyze each complaint separately, this is not called approach. Approach has to be applicable for all complaints, for all cases, regardless of what complaint you are dealing with, regardless of what case you are facing. Approach should be applicable, and it should help you to pick up the diagnosis. Okay, so let us try to apply some cracks in analyzing palpitations. Before starting some cracks, I will ask the usual questions. For how long has it been going over? Doctor, I have got this palpitations or this heart racing for 1 month, for example. Immediately, the second question after duration, is it the first time? Is it the first time? Because if it is not the first time, I will ask, have you ever been investigated before? Any diagnosis? Maybe already he was diagnosed. Okay, so is it the first time? It's very important. Immediately after the duration. Doctor, it is for 1 month. So you mentioned it is going over for the past 1 month. What about before this 1 month? Have you ever had the same episode of heart racing before? If he says yes, have you been investigated? Any diagnosis, any treatment given? Here, it will give me a clue about the diagnosis early on the consultation. Okay, and this is particularly relevant when your complaint is headache or abdominal pain. If your complaint from outside is headache and the patient told you that I have got frequent headache, basis-wise, you are dealing with migraine, full stop. If your case is abdominal pain and the patient told you, doctor, it is not the first time, I have got frequent episodes of abdominal pain. Your case, if it is basis-wise, your case is familial Mediterranean fever. I know familial Mediterranean fever is rare in real life. But if you are in basis exam, whenever the patient tells you that it is not the first time to get this tummy pain, doctor, I have got frequent episodes of tummy pain previously, most likely you are dealing with familial Mediterranean fever. Okay, so immediately after duration, is it the first time? If he say, no, it is not the first time, have you been investigated, any diagnosis, any treatment? And then I will go back to the complaint. Site. I have posted a picture to the screen if you can see. So site, and together with site is the radiation. Site and radiation, because radiation is another side. For example, the patient has got chest pain. Is it radiated to the left upper arms, neck, jaw? Doctor, I have got back pain. Does it go around your waist or down your leg? Doctor, I have got joint pain. Any other joint pains? Okay, because here it will help you to determine whether this is monoarthritis or oligoarthritis or polyarthritis. And if it is not the first time, so here you have got chronic intermittent polyarthritis. And if the site is the hand, chronic intermittent polyarthritis of the small joints of the hand. Here you are dealing with either rheumatoid arthritis if the deformity is not correctable, or SLE if the deformity is correctable. This is Jacot arthropathy. Okay, let us don't go in deep detail. So let us try to apply the same approach to our case. Palpitations, the site is known for palpitations. But what about radiation? Does it go to your neck? Do you feel bounding pulsation in the neck? If he say yes, there's a chance that you are dealing with Canon airwaves. And if the patient has had episode of syncope, for example, here you are dealing with complete heart block, Stokes Adam attack. Okay, so how did it start? Did it start gradually, suddenly? Okay, and together with the onset, always ask about the trigger. Doctor, I have got pain in the right knee. How did it start suddenly? Anything brought it in? Any history of trauma? Any history of injury? Immediately with the onset, I will ask about the trigger, because the trigger is the cause for the onset. Makes sense, right? And then I will move to the nature. So is it just fast heartbeats or fast and irregular? You can tap in the table. Okay, is it just fast heartbeat like this or irregular heartbeat? You can tap on the table to explain to the patient. Okay, this is the nature here. Then, is it getting worse or better? And anything makes it better or worse, like stress, caffeine intake, tea and coffee, and fizzy drinks. Okay, anything make it better? Usually, if it is related to thyrotoxicosis, he's going to say, no, doctor, I don't think it is related to taking coffee or exercise. Okay, so just a second. After analyzing any complaint, you will finish analyzing your complaint by asking about the associated symptoms. You can say associated symptoms, or you can say the system involved. Your patient has got chest pain, the system involved is the cardiopulmonary system. Your patient has got tummy pain and diarrhea, the system involved is the GI system, and so on. So our patient has got heart racing. It is the cardiovascular system. Okay, so immediately I will finish analyzing the system by analyzing the cardiovascular system. Okay, any chest pain, any breathlessness, okay, any fainting or near fainting episodes. I will finish analyzing the system involved, and then I will move to the constitutional symptoms. So what are the constitutional symptoms usually you need to ask about? 6 plus 2. 6 common constitutional symptoms you need to ask about. Weight, and weight is never important without appetite. It is never helpful without appetite. For example, previously, one patient presented to brought a case of dysphagia to the exam. If you ask, he will tell you, yes, doctor, I have got weight loss. Here, immediately, you will assume that this patient has got cancer. But if you ask about the appetite, he will tell you appetite is fine, but I cannot eat because of the dysphagia. So the weight loss is related to the dysphagia itself rather than cancer. We don't know the cause of dysphagia. It could be achalasia or Plummer-Vinson, or still you need more questions to know. So weight is never helpful without appetite. Lumps and bumps and itching. Why itching with lumps and bumps? Because it is the B symptoms of lymphoma. One of the B symptoms of lymphoma. Together with together with fever and night sweat. Fever and night sweats. Okay, so weight and appetite, fever and night sweat, lumps and bumps, and itching. And if you feel your patient is having a condition which is either endocrine in nature or autoimmune in nature, then you need to add 2 more important questions. Just let me take a sip of water, please. So if your patient is having a condition which you feel that it might be related to the endocrine system or something autoimmune in nature, you will add 2 important questions. 2 important questions. Why these two questions are important? Because whenever you have got autoimmune condition, you need to search for the associations. Whenever you have autoimmune condition, regardless of the autoimmune condition, you need to search for the rest of the autoimmune conditions. Let us assume that I am dealing with myasthenia gravis. I would like to search for other autoimmune conditions. So double D, diabetes type 1, type 1 diabetes. Okay, and Addison, both of them has got D on it. So double D, diabetes, and Addison, type 1 diabetes. Then double C, thyroid and celiac. I know thyroid starts with a T, but the pronunciation is thyroid. So double C, thyroid and celiac. Then double P, pernicious anemia and premature ovarian failure or ovarian insufficiency. Pernicious anemia and premature ovarian insufficiency. And then the rheumatological conditions. Okay, these are the associations. Doctor, this is too much to screen within the exam. So all you need is just 2 questions to screen for all these associations. 2 specific questions you need to add, and then the rest will come within the past. Medical history, within the systemic review, you don't need to add a specific question. So what are the 2 important questions? Have you got any dizziness on standing from sitting position? Have you got any dizziness on standing from sitting position? If this is positive, when I start my examination, I will make sure to check the blood pressure sitting and standing. I have got systolic drop in the blood pressure. What should be the next step in your examination? Any specific examination step you need to add?
Any tanned skin.
Exactly.
Autonomic neuropathy.
hyperpigmentation in the buccal mucosa. Buccal mucosa, by the way, it is not in the inner side of the lips, no, in the buccal region from inside. Okay, so the patient has got dizziness of standing from sitting position, postural hypotension, and hyperpigmentation in the buccal mucosa from inside, and hyperpigmentation around the knuckles of the fingers. Okay, so my diagnosis is most likely this patient of myasthenia gravis has got associated Addison disease as autoimmune association. Okay, so the first question is dizziness of standing from sitting position. The second question, have you got any weather preferences? Or you can ask the patient, are you abnormally sensitive to hot or cold weather? Are you abnormally sensitive to hot or cold weather? This is the most specific question which will give you the diagnosis, whether this patient is having thyrotoxicosis or hypothyroidism. Others are non-specific. Okay, immediately if he say, doctor, yes, I am always feeling hot, doctor. No matter how the weather is cold, I am always feeling hot. Your patient is thyrotoxic. If he says, doctor, I am always cold, I cannot tolerate cold weather, I am always feeling cold, no matter how the weather is hot, I always feel cold, your patient is hypothyroid. Okay, so immediately I will finish the symptoms of thyrotoxicosis. Immediately I will finish the symptoms of thyrotoxicosis. Just a second, let me share a picture. So just to help you remember, yeah, are you able to see the picture? Is it clear?
Yes, doctor.
It is a simple, just to remember the symptoms of thyrotoxicosis: sweating. S for sweating, the W is for weight loss, E for emotional liability, increased appetite. Okay, so our patient mentioned weight loss, and when you ask about the appetite, she told you that, doctor, I have got a very good appetite, I'm eating well, doctor. So here, this is a hint, another hint for thyrotoxicosis, by the way, because we have got 3 differential diagnoses for weight loss and good appetite. Any idea?
Malabsorption syndromes.
Exactly. So it is
Celiac.
either thyrotoxicosis or diabetes, thyrotoxicosis or diabetes, or not celiac, malabsorption syndrome. Malabsorption syndrome. Yes, any malabsorption. Okay. Then the T is for tremor, and it can be also for tachycardia. Okay. Then intolerance to heat, nervousness, goiter, and GI problem like loose motion. So far, the patient from outside the complaint was tachycardia. Okay, so this heart rating is finished. Okay, inside, when we did analysis of the main of the constitutional symptoms, he mentioned weight loss and appetite was okay. Okay, when we asked about the triggers, we did ask the patient, are you feeling anxious, nervous, on the edge, anything make this heart racing worse? Okay, so we covered nervousness as well. Okay, so just few questions and you can cover all the thyrotoxicosis symptoms. Any excessive sweating, you can ask in the history or you can examine for this. Okay, and then any shakiness of the hands, any loose motions. So one of your mistakes, Dr. Ala, when the patient mentioned loose motion, you did not analyze
Yes.
Exactly. And he also mentioned, doctor, I do not have tummy pain, but I have got bloating, gaseous distension. So whenever you hear loose motion or you hear any positive complaint, you have to analyze that complaint. So is this loose motion, just simple loose motion with thyrotoxicosis, or it is steatorrhea as part of celiac disease as autoimmune association? We have to analyze to know. So is it pale, bulky, difficult to flush? Pale, bulky, offensive, and difficult to flush. If he says yes, this is not diarrhea, this is steatorrhea. So does it get worse with any specific type of food like bread and pasta? Yes, doctor, your diagnosis here is celiac as autoimmune association. So whenever the patient mentions any positive complaint, you have to do full analysis. Even if you detected this positive complaint within your systemic review or past medical or whatever, whenever the patient mentions positive complaint, try to do some analysis. Okay. So far we did complete the analysis of the main complaint. We completed the system involved, which is the cardiopulmonary system. We completed the constitutional symptoms. Okay, and we detected thyrotoxicosis. We finished the symptoms of thyrotoxicosis. Okay, and we did ask within the constitutional symptoms also about Addison as autoimmune association. Okay, so these are the associations. What about the complications? What complications could be associated with Gravis disease? Any idea?
Ophthalmopathy,
AF.
cardiac failure,
Atrial fibrillation and heart failure. Okay, what else?
Osteoporosis.
ophthalmopathy,
Osteoporosis.
Symptoms. Compression symptoms. So you need to ask about the triple D. Dysphagia, dyspnea, especially on lying flat. They will have dyspnea on lying flat not because of heart failure, but sometimes because of large goiter compressing the trachea when the patient is lying flat, especially when the patient is lying flat. So it is triple D. Dysphagia, dyspnea, and also dysphonia. Dr. Ala, I think she did ask about all of them. So compression symptoms in the form of triple D, dysphagia, dyspnea, and dysphonia. Okay, and then Gravis ophthalmopathy. Gravis ophthalmopathy might affect the vision. The patient might tell you, I have got blurred vision. And he might tell you, I have got diplopia. Okay? So the blurred vision could be because of dryness, which might lead to corneal ulceration, okay? And also, it might be related to optic atrophy. When we discussed the optic atrophy, if you attended the session with me, we mentioned that the causes are icing plus TNT. Icing plus TNT. Okay, so the C was compressed nerve. This compressed nerve could be because of SOL, space occupied lesion, or it could be related to soft tissue swelling as a result of Gravis disease. Okay, so the blurred vision could be related to dryness and corneal ulceration, or it could be related to optic atrophy. So it's a must to request, at least request, if you do not want to do the fundus examination, at least request fundus examination, and within your plan, you have to suggest urgent ophthalmology review. Urgent ophthalmology review, because this patient might end up blind. It will affect your clinical judgment. Okay, so what about diplopia? What is the cause of diplopia in patients with Gravis disease? Any idea?
infiltration of the muscles.
Ophthalmoplegia, yes, ophthalmoplegia. So Gravis, by the way, Gravis ophthalmopathy, we have got type 1 and type 2. Type 1 and type 2. If the muscles are affected, the muscles of the eye are affected, I mean, if the patient is complaining of diplopia, this is type 2. Okay, sometimes the patient might have ophthalmoplegia, and the ophthalmoplegia might be very subtle, that you cannot detect obvious cranial nerve abnormality or obvious abnormality with the eye movement. But the patient will tell you, I have got double vision, doctor, when you try to examine for the eye movement. Okay, so complications, it is either Gravis ophthalmopathy or related to compression symptoms or arrhythmias and heart failure. Okay, now we know the complications and the associations. So we mentioned, in order to search for the 7 associations of autoimmune condition, you just need to add 2 questions. Whether preference for thyroid disease, dizziness or standing from sitting position for Addison. What about celiac? Anyway, when you cover the systemic review, you will come to search for the GI symptoms. So any problem with your bowel, doctor, I have got loose motion. I will analyze this loose motion. If it is simple diarrhea, then this might be as part of thyrotoxicosis. If it is steatorrhea, especially with bread and pasta, this might be related to celiac disease. When I come to the genitourinary system, let us assume that the patient mentioned polyuria. Doctor, I visit the toilet to pass water more frequently now. And he has weight loss also. And he has autoimmunity. What are you thinking
Type
about
1
now?
diabetes.
Type 1 diabetes. Exactly. Type 1 diabetes. So, doctor, I have got joint pain, swelling, stiffness, skin rash. Here you are dealing with one of the rheumatological conditions or mixed connective tissue disease. Okay. And then whenever you finish the systemic review, you will finish the systemic review by the female history, if your patient is female. Female history is a must in any female if you are dealing with one clinical consultation. So in order to cover the female history, you have to ask the 5 P's. 5 P's, period. Usually thyrotoxicosis will result in amenorrhea or oligomenorrhea. Amenorrhea or oligomenorrhea. Although, by the way, anything can happen. It is not a rule that hypothyroidism will cause menorrhagia and thyrotoxicosis will cause amenorrhea. Anything can happen, okay? If the patient is pregnant, sometimes gravis will flare during pregnancy. If the patient has got recent baby or recent delivery, okay, then here there's a chance that you are dealing with postpartum thyroiditis, although it will not result in thyroid eye disease, right? However, if you are dealing with thyrotoxicosis, other type of thyrotoxicosis, and the patient told you, doctor, I have got recent delivery, then you have to think about postpartum thyroiditis. Okay? Abortion associated antiphospholipid disease. Okay, antiphospholipid syndrome. Okay, just one more question. If your patient has no obvious thyroid disease within the past medical history, you need to ask about recent infection, recent throat pain and fever, and so on. So what would be the diagnosis here?
Thyroiditis.
Decurrence thyroiditis or post-viral thyroiditis. This is very important because when you come to the plan, you will not suggest antithyroid drugs, non-steroidals, sometimes steroid. If the patient did not improve or the thyroid function did not improve, then you can start antithyroid drugs. So within past medical history, if the patient is having diabetes, he will tell you, doctor, I have got diabetes and I am taking insulin, for example, okay, as autoimmune association. Okay, so if this patient had type 1 diabetes and he has thyrotoxicosis, do you think I can tell the examiner that the diagnosis is autoimmune polyglandular syndrome?
Yes, you can.
Yes. What do you think?
Can you repeat the question, doctor?
Mm.
I think no.
The patient has got type 1 diabetes mellitus and Gravis disease. What do you think? Is it autoimmune polyglandular syndrome?
No.
No, it's
The
mandatory
thyroid
to
should
be Addison.
hyperfunctioning.
Exactly.
No.
Exactly.
Hi.
This is just autoimmune association. But in order for you to say that this is APS, you have to have 2 Ds. The first 2 Ds, it must be available. Type 1 diabetes and Addison. Type 1 diabetes and Addison. Usually it is associated with thyroid disease, but not thyrotoxicosis. Usually it is hypothyroidism. Hypothyroidism. Okay? So the
doctor,
first 2 Ds, yeah.
the mandatory to say autoimmune polyglandular disease, Addison and type 1 diabetes, both of them?
Yes, exactly.
Yes.
Okay, the first 2 Ds in our association, the first 2 Ds. Okay, and if you have got thyroid disease, most likely it's going to be hypothyroidism rather than thyrotoxicosis. Okay, so after I finish the systemic review and the female history, I will come to the PDFs. Within the past medical history, I will ask about type 1 diabetes and recent respiratory tract infection for decurvence thyroiditis within the drug history. General questions. Okay, are you on any medication? Show me your medication list. Are you allergic to any medication? Any over-the-counter medication? Sorry for the question. Any illicit drugs? And then, if he's taking thyroxine, this might be the reason behind his thyrotoxicosis. Okay, then I will come to the family history and then the social history. Within social history, smoking and alcohol, yes, it's a must, especially smoking. And immediately I will give advice against smoking. Why? Because it will make gravis ophthalmopathy worse. And if you do not stop smoking, this is going to affect my clinical judgment, because my plan is never sensible if I do not stop the patient from smoking. Okay, and most importantly, I have to ask also about the impact of the disease. How does this disease affect you? How does it affect your life or job? Okay, this is very important. Okay, if you do not ask this question, the examiner might deduct some marks out of your clinical communication skills. Okay, then whenever your patient has got vision problem, whenever your patient has got vision
Driving.
problem and he is having Gravis disease, this is dangerous, by the way. It will endanger your clinical judgment if you do not take care. Because if you do not stop smoking, they will deduct some marks out of your clinical judgment. If you don't stop driving, they will deduct some marks out of your clinical judgment. If you do not suggest urgent ophthalmology review, they will deduct some marks out of your clinical judgment. If you do not offer, for example, lubricant eye drops to the eyes to protect the eyes, some examiners might deduct some marks out of your clinical judgment. Despite you got the diagnosis, you suggested investigation and treatment, you will find that you got 0 within clinical judgment. So take care whenever a patient is having Gravis ophthalmopathy. Okay, you have to stop driving and also to notify the DVLA. It is not just you stop driving. Stop driving and notify the DVLA, please, because it is dangerous to continue to drive while you are having vision with your eyes, a problem with your vision. This will put you and the public at risk. Then after I finish my history, have you got any questions or concerns for me today? Okay, doctor, what is wrong with me? Is it cancer? Is it problem with my heart? What is wrong with me? Please tell me. I am really worried about my heart. So I am going to explain everything and I am going to address all of your concerns. Just before that, I would like to examine you if this is okay. Here, immediately, I will take permission for examination before I answer his concerns. Okay, then when you start examination, VLS, our usual approach for examination. V is for the vital chart. It is mentioned from outside and it has got findings you have to mention to the examiner, by the way. If he tell you what findings in the examination you were able to detect, okay, and from outside it is mentioned that the patient has got tachycardia and wide pulse pressure, and you do not mention this, he might deduct some marks out of your skill B, especially if he's a tough examiner. Okay, so take care. Whenever they give you a vital chart from outside, it is never given purposelessly. When I start presenting my finding to the examiner, okay, this patient has got tachycardia, wide pulse pressure, large volume, pulse, atrial fibrillation, Gravis ophthalmopathy. Okay, I will mention all the findings, okay, including vital chart from outside. So the V is for the vital chart. With the vital chart, I'm going to add blood pressure sitting and standing. Okay, so I would like to have a look at this patient vital chart, same as outside. Okay, at this stage, I would like to check the blood pressure sitting and standing. Okay, if there is associated Addison, the examiner is going to tell you, yes, there is postural drop in the systolic blood pressure, more than 20 millimeter mercury, for example. So here I will put Addison at the back of my mind. When I start my screening, my survey, I will examine the buccal mucosa for hyperpigmentation. So after finishing the vital chart, I will come to the local examination. Here I will stop and think which complaint the patient had. He had palpitations. So I would like to examine the heart and the pulse. He had weight loss. No specific examination for this. He had blurred vision. So I have to examine the eyes and vision. Okay, so I will start by the eyes. Within the local examination, I will start by the eyes. The eyes from the front by just inspection. Just a minute, I will share a picture. There, for the eyes, there is examination from the front, side, and from above. Okay, front, above, and side. Front, above, and side. Just a minute. From the front, I will examine for exophthalmos, lid retraction, and chemosis. ELC. ELC. Exophthalmos, lid retraction, and chemosis. Exophthalmos, lid retraction, and chemosis. So, what is the difference between exophthalmos and lid retraction? Any idea? What is the difference between exophthalmos and lid retraction?
I think exophthalmos you will see below the pupil. Lid retraction you will see above the pupil. The white above the pupil.
Excellent, excellent. So if there is lid retraction, you will be able to see the whitish sclera above the pupil or above the corneal limbus. Okay, just a minute. Exophthalmos you will see above and below. Okay, so exophthalmos, as you can see, I can see the whitish sclera below the pupil. So there is exophthalmos, and I can see it also above the pupil. So this is lid retraction. Okay, and as you can see, the red color or congested capillary at the corner of the eyes. This is chemosis, not ecchymosis. Ecchymosis is bleeding under the skin, by the way. This is called chemosis. Congestion and swelling of the eyelid. This is called chemosis. Okay, so from the front side, ELC, exophthalmos, lid retraction, and chemosis. And then I will go behind the patient and I will look from above his head to confirm proptosis or exophthalmos. Okay, if the patient has got proptosis, you will be able to see the eyeball in front of the eyebrow. Are you able to see in the picture? Which side has got proptosis or exophthalmos?
The left.
Left.
Side.
Exactly. So from the front side, then from above, then I will come to the patient side, the right side of the patient. I will put my index finger around 30 centimeters in front of the patient eyes. And then I will tell the patient, keeping your head still, please follow my finger. Keeping your head still, please follow my finger. So I will go up in the direction of this black arrow and then down in a curve, just like the red arrow. Okay, what do you expect to find if the patient has got lid lag? What do you expect to find? I will share a video and tell me the finding. Okay, just a second. Are you able to see the screen? Are you able to
Right
see?
eye, I see leg. Yes.
Clear, yes.
So what do you see? When the pupil go down, the lid is lagging behind during the movement. The lid is lagging behind during the movement due to hyperactivity due to thyrotoxicosis. This is called lid lag. And sometimes you need to pull the corners of the eye to be able to see the congested capillaries. Okay, so from the front side, just to finish. Okay, so from the front side, exophthalmos, lid retraction, and chemosis. From above, confirm proptosis. From the side, lid lag. Okay, and then I will come to examine the vision as usual. Acuity, field, movement. Most importantly, you have to instruct the patient to tell you if he has got diplopia. Okay, and then suggest fundus examination. Then I will go down to examine for goiter. I will go down to examine for goiter. When you start examination of the goiter, again, you have got from the front side and from the back side. From the front side, I will tell the patient to take a sip of water. Okay, to take a sip of water and then swallow. And then I will be watching for movement of the thyroid gland above and down with the swallowing. If you can see in the screen. Are we able to see the video? So just look when the patient swallows the water. Even if the goiter is very minimal, it's going to be very clear. Clear? Clear, right?
Yes.
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 So from the front side, just I will ask the patient to take a sip of water. This is all what I need. And by the way, especially in Egypt Center, the patient will hide the bottle of water beneath his shirt. Unless you ask for it, he will not show you the bottle of water. Okay? So from the front side, I will ask the patient to drink a sip of water, and then I will go to the back side. Okay? From the back side, I have got feel and feel, and then auscultation and percussion. What do you mean by feel and feel? The first feel is for the thyroid gland itself. The second feel is for cervical lymphadenopathy. So not to forget. This is very important, by the way. And then percussion and auscultation. Percussion, I will start from down and then go up toward the sternal notch. If you get any dullness to percussion, this is retrosternal extension of the thyroid. Okay, then I will auscultate for thyroid bruit. Once I finish examination of the eye and the thyroid gland, my local examination is finished. I will move to general survey, starting by the hand. Hand outstretched, I have got 2 findings. Hand relaxed, I have got 2 findings. Okay, so hand outstretched, I will search for tremor, and I will take 1 finger looking for thyroid acrobacy. Then hand relaxed, I will look for palmar erythema, and then using the dorsum of my fingers, I will swipe the patient hand to look for any sweating. Hand outstretched, tremor and acrobacy. Hand relaxed, palmar erythema and sweating. Then I will take the pulse. From outside, it is mentioned tachycardia. Is the patient in atrial fibrillation? Then I will move to the arms for proximal myopathy, eyes for pallor jaundice. Okay, neck is done. I will move to the chest, auscultate the heart, then lower limb for myxedema. Okay, just quickly do general survey to finish your examination. I finish my examination, I will come to explain to the patient and answer his concerns. So whenever you are trying to explain a disease to your patient in long clinical consultation, you have to cover 3 points: disease, plan, advice. Disease, plan, advice. Disease, plan, advice. Disease, your problem are caused by a medical condition called Gravis disease. It happens because of your defense system attacking the gland at the front of your neck and eyes. This will make the gland overactive, producing more hormones, which result in manifestations similar to your problem. Here I did explain the disease. I will move to the plan. We need to run some investigations to confirm the diagnosis. Once the diagnosis is confirmed, we will involve the gland doctor and the eye doctor, and we will start you on treatment to control the disease. Treatment, I am not going to tell him medication or surgery because this is for the team to decide. So we will run some investigations to confirm the diagnosis. Once the diagnosis is confirmed, we will involve the gland doctor and the eye doctor, and they will start you on treatment to control the disease. So disease finished, plan finished, I will move to advice. Meanwhile, or in the time being, I advise you to stop smoking because it will worsen the eye problems. Use eye lubricants. Stop driving unnotified, the DVLA, according to my case. So disease, plan, advice. Disease, plan, advice. Okay? Usually for smoking and alcohol, please, whenever the patient mention I am smoking, advise against smoking. I am drinking alcohol, advise against drinking. Don't keep it for the end of the consultation because believe me, under the stress of the exam, you might forget. Okay? So disease, plan, advice. So what is your diagnosis? My diagnosis is Gravis disease, complicated by atrial fibrillation or sinus tachycardia, according to your manifestation. I was not able to identify any compression symptoms related to goiter, for example. I will mention the disease, the cause, the complication, and association. For example, the patient mentioned steatorrhea, possibly associated with celiac disease. How are you going to investigate this patient? Investigations include basic investigations. Apart from basic investigations, I would want to do thyroid function test, thyroid autoantibody. And don't forget the main complaint. He presented with tachycardia, so ECG, possibly Holter monitoring if needed. Thyroid ultrasound, uptake scan if needed. Investigation for association and complications as appropriate. For example, my patient has got features suggestive of celiac, weight loss, steatorrhea, especially with bread and pasta. So here I will order investigation for celiac. Management. Management is fixed again. Multidisciplinary team, including. Then I will think about my case. Like a robot. What is your management? I will start multidisciplinary team, including. Then I will think about my case. So my case is Gravis, including the endocrinologist. He had Gravis ophthalmopathy and he has visual complaint. And he will need to be reviewed urgently also by the ophthalmologist. So this multidisciplinary team is going to treat the patient using two types of treatment, non-pharmacological treatment and pharmacological treatment, and sometimes surgical treatment. So non-pharmacological treatment, patient education and counseling and so on, stop smoking, stop driving, blah, 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 blah. I will finish the non-pharmacological treatment and then I will come to the pharmacological treatment. Pharmacological treatment includes symptomatic treatment. I will give, for example, beta blockers, propranolol, antithyroid drugs, whether you can give carbimazole or propylthiouracil if the patient is pregnant, okay? And sometimes steroids. Steroids for what? For Gravis ophthalmopathy. Sometimes they give other options like one medication, the name is teprotumumab, I think, teprotumumab, yes, teprotumumab, very difficult to pronounce medicine. And sometimes they can do even orbital radiotherapy, or sometimes surgical treatment. Surgical treatment can be decompression surgery, can be tarsorrhaphy. Tarsorrhaphy, they will try to suture the corners of the eyelids in order to treat the exophthalmos. Just a minute, let me see if I have a picture. Yes. Okay, so they will suture the corners of the eye to minimize the exophthalmos. Okay, so surgical treatments apart from thyroidectomy, tarsorrhaphy or orbital decompression surgery, and so on. Okay, why we didn't mention radioiodine treatment? By the way, the examiner is going to ask you. The patient did not respond to medical treatment. Yeah, if you say radioiodine treatment, he will kill you within the clinical judgment because it will worsen the thyroid eye disease. Okay, same as prophylaxis in migraine. The patient presented with complex migraine, I mean hemiplegic migraine. So if you mention the regular medication we use it for migraine, it will be a problem because most of them either contraindicated or controversial to use in complex migraine. Okay, are we clear? This case is very simple, by the way, and straightforward. And most of the time, they will not bring any association or there will be no more complications. But you have to search for them. If you do not search for them, it will be a problem because it is never about the diagnosis, as we mentioned. Okay, is it clear? Any question regarding this case?
Sorry, doctor, it's not that much important. Just for my information, we can offer lithium for patient as well.
Again, please.
Lithium in the Graves or hyperthyroid disease.
For what exactly? As
for thyroid. Yes.
I don't know really. I'm not sure about this. I never came to my knowledge that we can use lithium in. What I know, lithium is usually for bipolar personality disorder, and it can result in nephrogenic diabetes insipidus. But in Gravis, I cannot recall.
Okay, thank you.
Also cause hypothyroidism.
Lithium for hypothyroidism, you mean?
No, it causes hypothyroidism as a side effect of it.
Okay. Yeah. Together with amiodarone, as I remember, amiodarone can cause amiodarone-induced thyrotoxicosis or hypothyroidism. Okay, so
No,
if
no,
question,
can can used in I think in thyroid storm.
thyroid storm, lithium. I do not
Yes.
remember really. Let us check it out and we will see.
Yes. Doctor,
Okay,
I have
so
one question,
yeah,
but
please, yeah.
not for this case. Not for this case.
No problem. Tell me, please.
You mentioned about complex migraine. So what's the treatment of the complex migraine?
So, if a patient presented with complex migraine, he is going to be suspected TIA because you are going to apply Royce's scoring. Okay, he has weakness, so this is +1. TIA cannot be excluded. According to the new guidelines, NICE guidelines, July 2019, you are not going to use ABCD scoring. Okay, it is not required. You are going to use other scoring to determine the probability of TIA, like Royce's scoring. So if the patient presented with complex migraine, according to scoring, most likely you're not going to be able to rule out TIA. So here you need to suggest that the patient is going to need urgent assessment by neurologist within 24 hours.
24 hours.
24 hours. So the neurologist is going to do two things. First, he's going to look into the possibility of TIA and stroke, and also he's going to select appropriate and prophylactic treatment for complex migraine. Full stop. This is how to escape from this question. No need to go and search. By the way, there is no clear answer. Okay, some resources will tell you that it is controversial. Some resources will tell you it is contraindicated. There is no clear answer. Believe me, I have searched. There is no clear answer. Anyhow, you can answer this in a simple and smart way, and also at the same time cover your clinical judgment. Suggest neurologist assessment within 24 hours to look into the possibility of TIA, to exclude TIA, and also the neurologist will select appropriate and safe prophylactic treatment for complex migraine. Is it clear?
Yes, Doctor.
Okay. So,
sorry, just one question.
Yeah, please.
During examination or taking history, when patient told me that has a dryness in the eye or any pain in the eye, if the same time I tell the patient that I will provide some eye drop or the ointment for this problem, is it okay or need to end of the
even better because you will not forget by the end of the session. However, if you forget, you can add it to the advice part, disease plan advice, but you can right away offer, just like whenever the patient tell me, doctor, I have got chest pain or joint pain, immediately I can offer painkillers. Don't worry, I will offer you some painkillers to help with the pain. This is completely fine.
Yes.
Doctor, what are the other causes of palpitation if the eye problem in thyroid is not that much prominent?
Again, please, other causes of palpitation, what?
Palpitation, a differential diagnosis of palpitation if the eye problem and thyroid is not that much prominent.
Differential diagnosis for palpitation is very wide. It's very wide. It can be anemia, it can be arrhythmia, it can be valvular abnormality, it can be. However, in the exam, you are going to take full history and you are going to do examination, and according to that, you can narrow the list of differential. Okay, but palpitation is a huge topic. Even drinking coffee can cause you palpitation. Stress can give you palpitation. Exercise can result in palpitation. But I'm not going to diagnose the patient with a single information. Full history, full examination, and then I will be able to give a diagnosis, the most likely diagnosis, and then I will put a list of differential also. Okay. So this is
going to rule out the other. Are we going to rule out the other differential diagnoses by asking questions about them in the history, like a heart problem and
not necessarily
anemia?
For this patient? It is obvious he has got goiter, he has got Gravis ophthalmopathy, and you auscultated the heart, it was normal. So most likely this is Gravis ophthalmopathy. Still, I'm going to suggest ECG, X-ray, and echo. I'm going to suggest thyroid and thyroid autoantibodies. This is to do what? To rule out the differentials and confirm the diagnosis, right?
Okay.
Okay,
Right.
so because we are running out of time, please, if you have any question, post it in the group. We will stop here. Thank you for attending the session of today.
Thank
See
you
you
so
next
much.
Thank you, doctor. Thank you very much.
Thank you. Thank you. Goodbye.
Thank you, doctor. Thank you.